So for our next lecture, we have Dr. Richard Kelly, who's going to be talking to us about the ACA today. He is a full professor at the University of California. He studied biochemistry and theology as an undergraduate at Harvard. Following graduation, he was awarded a full-time scholarship to study public health at the University of Berkeley. Dr. Kelly went on to pursue a dual professional degrees in both JD and MD. He also currently has medical interests where he focuses on anesthetic management of surgical patients with complex cardiothoracic diseases. He currently does public health research. Interests include the consequences of the ACA, opioid intolerance and addictions. Additionally, his legal interests include ethical and legal implications of for physicians. Currently, he is also a member of the American Society of Anesthesiologists and the American College of Legal Medicine. And he's currently an active member of the World Association of Medical Law and a member of the Bar of the Supreme Court of the United States, to kind of wrap up many of Dr. Kelly's achievements throughout his career. And we welcome you.
Thank you very much. It's a little late in the afternoon. Thank you, everybody, for being here. So I am going to be talking about the Patient Protection Affordable Care Act. Let me see if I can share my screen here. Where is it sharing? Share screen. Where are you? Oh, here we are. Okay, I hope everybody can see that.
We can.
You can? Yes, no?
Yes.
Yes. Okay, fantastic. That's one of the problems with Zoom, is that it doesn't tell you what everybody else sees. And I think that that would be very helpful if they actually corrected that. Okay, Patient Protection and Affordable Care Act, also known as Obamacare, or just the Affordable Care Act, or the ACA. All right, let's start with something that we actually covered yesterday. I want you to listen to this once more with new ears.
We will eventually be spending more on Medicare and Medicaid than every other government program combined.
I'm not sure if it's muted, but the audio is not coming through on my end, Dr. Kelly.
The audio is not coming through. All right, let's try and fix that one. Let me unshare and see if I can share this again. My apologies. Thank you for letting me know. Okay, let's try this one more time.
It might just be a matter of turning up the audio directly on your video on the slide.
Oh, you think so? Well, let's try this.
Because I could hear it faintly. It wasn't completely off.
Oh, really? All right. Well, let's turn the volume all the way up there. And let's see if I can turn the volume up over here. All right. All right, tell me if you can hear it now.
Finally, our healthcare system is placing an unsustainable burden on taxpayers.
Is it better?
Yes.
Healthcare costs grow at the rate they have. It puts greater pressure on programs like Medicare and Medicaid. If we do nothing to slow these skyrocketing costs, we will eventually be spending more on Medicare and Medicaid than every other government program combined. Put simply, our healthcare problem is our deficit problem. Nothing else even comes close. Nothing else. Nothing else. Now, these are the facts. Nobody disputes them. We know we must reform this system.
All right, so they knew back, this was June 9th, 2009. They were talking about it then, right? Cost of healthcare, let's do something about it. So I want you to bear this in mind because we're going to come back to this at the very end of the lecture, right? The reason that Obamacare came into existence was to control costs. Okay, so this was June 9th after a lot of wrangling. On March 23rd, 2010, then President Barack Obama signed the Affordable Care Act into law. And you can see a lot of the players there. You see Nancy Pelosi, who was the majority in the House of Representatives, Harry Reid in the Senate, Waxman, Brady. You see there's Joe Biden there as well. And if we were in a classroom, I'd ask you who that little kid was. But since we're not, some people thought maybe it might be Obama's long-lost son, but no, it's not. This little boy there, his name is Marcellus Owens, and he's from Seattle, Washington. He was 11 years old at the time of signing. He lost his mother when he was 8 years old. And so his mother was a single mother, took care of him. She had a good paying job, and she got health insurance through her job. She developed idiopathic pulmonary hypertension, and so she regularly saw her doctor and got her prescriptions filled. But then at some point, she got a little too weak to even be able to go to work. So they fired her. And when they fired her, she lost her insurance. And when she lost her insurance, she could no longer visit a doctor and she could no longer afford her prescription medications. And as a result, she died. And so she died because she did not have health insurance. And so now this young man at the time of signing was an orphan because there was no health insurance available for his mother. So that's why he's there. And actually, an interesting aside, not to divert too far away, but an interesting aside is that somebody came up to me a couple of years ago and said, you know what happened to that kid? And I said, no, I don't. He goes, well, he's about 21 years old now, and he decided to take care of, to undergo a sex transformation using his Obamacare insurance. So he was able to take care of that as well. Interesting. Okay, something that's not well known is there are actually two legislative, when we talk about the Affordable Care Act, there are actually two legislative acts. The first one, which is called the Patient Protection Affordable Care Act, is the one that we saw signed with a lot of fanfare. And the second one is the Healthcare and Education Affordability Reconciliation Act that was signed a week later. So the reason that they had to do this is actually long and complicated. Because they passed it in the House along basically party lines. There are more Democrats in the House than there were Republicans. They passed it along party lines. It went to the Senate, and the Senate had just enough. They had 60 votes to prevent a filibuster. And so what happens is it gets passed in the House, then it gets passed in the Senate. The Senate makes some changes. Then it has to go back to the House and get repassed, and then go back to the Senate and get repassed. After it passed in the Senate the first time, Senator Edward Kennedy died, and to everybody's surprise, a Republican was elected to fill his spot. And then there was also the midterm elections in the House, and actually the Republicans became the majority there. So there was a big problem because now they couldn't pass it that way. The only way they could pass it was through this Reconciliation Act, which meant that they couldn't really touch the original legislation, but they had to go back and do this through the reconciliation process and actually plug all the holes. There are more than 1,000 instances where they said the Secretary of Health and Human Services at his or her discretion shall do such and such because they just didn't have time to fill it in. So that's what this Reconciliation Act did, is fill in all those blanks. The bill itself is almost 11,000 pages long. So I don't know too many people that have read it through and through, but it contains a lot of stuff and it's really quite complicated. And this is kind of what somebody summarized the Affordable Care Act to be. You can see that there are a lot of players involved. In the upper left is a president, and the upper right is Congress, and the lower right is patients, and then in the lower left are physicians. The Secretary of Health and Human Services kind of coordinates everything, and there are lots of programs in there. There's Centers for Medicaid Services, there's PCORI, there's the there's this institutional watchdog for Medicare. There's the government health benefit exchange. They're all in there, and it's very, very complicated. But to understand it is to understand the broad overview is not that difficult. If you think about the Affordable Care Act as being a three-legged stool, there are three major provisions of the Affordable Care Act that prop it up. And if any one of these three legs is somehow impaired or destroyed, it destroys the entire Affordable Care Act. It cannot support itself without all three legs. And the Republicans have tried very hard repeatedly, over 70 times, to try to destroy the Affordable Care Act. But they focused, they knew that they only had to get one of these three legs in order for the Affordable Care Act to collapse. Fortunately, to this date, it hasn't. But these are the three legs. Number one is to insure the uninsured. That is, that there were 50 million people that were uninsured in the United States, and this act was to insure them all. The second was to reform health insurance. Health insurance was out of control, and was making profits, 50% profits, and only insuring the healthy and wouldn't insure the sick. And then also to improve quality and reduce costs. So that is a big thing that is very important to the federal government, is to try to reduce cost. And they felt that in doing so, by improving quality, they could also reduce costs. So these were the three parts of the Affordable Care Act. So let's take a look how they were planning to insure the uninsured. First of all, which I'm sure you've all heard of, is the individual mandate. That is, every U.S. citizen must have health insurance, and you have to pay a penalty if you don't have health insurance. That currently is up before the Supreme Court of the United States as to whether that is valid constitutionally. And that's another story. It's been a couple of years, and now the story has gotten increasingly more complicated. But this was the original plan. So everybody has to have a health insurance. And if you don't, you pay a penalty. So as soon as the Affordable Care Act rolled out, if you didn't have health insurance, you paid $95 or 1% of your family income. And then it went up to $325 the next year, and then $695 the following year, or 2.5% of your family income. So this was the carrot and the stick. The carrot being, yes, go and get health insurance, you'll be covered. The stick is, if you don't, you're going to have to pay a penalty. And this is how they envisioned it would, everybody would eventually be covered. First of all, they want to take care of the younger generation that were notoriously uninsured. So they said that parents could insure their children up to the age of 26. Before, it was up to the age of 18. But many of these younger people were just starting out in their careers. They couldn't afford rent, food, and health insurance, and therefore often decide, and because they were so healthy, often decide to go without. But parents, being older and wiser, felt that perhaps their kids ought to have health insurance, and this was actually probably the most successful portion of the Affordable Care Act. There were a large number of children whose parents covered them for their health insurance. The second way is by direct enrollment, just in the same way that you go out and you get insurance on your car, or if you own a home, get homeowners insurance, or any other kind of insurance. You can call up the insurance company and say, I want some health insurance, and just directly enroll with them. The third way was through the employer. Now, in the United States, about 50% of everybody is insured through their employer. Now, before the Affordable Care Act, there was no requirement that employers offer health insurance to their workers. And states were generally barred from imposing such requirements because of something called ERISA preemptions. So employers were doing it voluntarily. And the reason they were doing it voluntarily is because the federal government was giving them a break on their taxes. So if they spent money on employee benefits, they could exclude that from taxable income. So they figured instead of paying taxes, they'll just give another perk to their employees. But employers weren't required to do it. But the ACA made it mandatory for employers to insure their employees, and it was called the employer mandate. Now, this is a little bit of a busy slide, but starting before this slide, any employer that has over 200 employees just had to insure all of their employees. So think about Google or Apple or whatever. They have to, or UC, Irvine, they have to insure all of their employees. So the question was, what happens for people who have employees between 50 and 200 or less than 50 or less than 25? And this is where all the controversy was, and there was lots of ink spilled about the employer mandate. But the employer mandate basically said, if you have 50 employees or more and less than 200, then you should offer coverage. But if you did offer coverage, everybody had to be covered. So therefore, let's take a law firm, for example, had like 70 employees that included the attorneys and the paralegals and the secretaries, and also somebody that came in at night and swept the floors and emptied the garbage. So if this employer, this law firm, decided to offer health insurance to everybody and said, well, we'll just take it out of your paycheck, but then one or more of them found it unaffordable. For example, the person that came in at night to clean the floors found the health insurance unaffordable and decided to go to the federal exchanges instead. Then that employer would be penalized $3,000 for every full-time worker that actually went to get their insurance on the exchange, because in the exchange, the federal government was subsidizing that. And we'll get to the exchanges in a little bit. Now, so that was really the only thing. Every other scenario didn't have to worry about. But if you actually offered health insurance that really only the attorneys can afford, and those that were paid less by the law firm couldn't afford, then you had to pay a penalty. Now, if you had fewer than 50 employees but more than 25, then you could offer coverage. But if you didn't, then they're allowed to go to the exchange without any problems. Now, just go back. I skipped the point. If you're in this 50 or more employee range, and the employer doesn't offer coverage, and so they say, okay, all the attorneys, we're just going to give you a bonus in your paycheck or whatever, give you more. You go out and find your own health insurance. But if anybody in that law firm then went to the exchange and qualified for a tax credit, then the employer would be fined $2,000 per year for each full-time worker. So it was to discourage employers from creating something that disadvantaged some of the employees who would not be able to afford the insurance. And so this was a requirement that everybody with 200 employees more had to insure them, or if it's between 50 and 200, they had to do it in a way that was fair. And then under 50, there was no requirement. So you think about under 50, like a landscaping business. There was no requirement for a landscaping business to insure all of their employees. Okay, so that's how they exercised the employer mandate. Then there was the exchange, and this was new. This was new for the Affordable Care Act. And the whole idea was to create an exchange where everybody could, instead of calling up Aetna and then calling up United Health and calling up Anthem Blue Cross, you could actually get onto a website and shop and compare. If you're of childbearing age, maybe you want something that had a little bit more, obstetric kind of coverage. Or if you're older, maybe something that included a gym membership or something. So you could actually go and comparison shop. So it's like getting onto Amazon, and all the insurers would then put all their programs onto this website, and then you could just comparison shop. So this was a new idea where people could get health insurance and could cost compare and also compare all the different kinds of benefits. And the idea was either a state would take full responsibility for it, which California did. They had what is it? California covered California. So the states could actually take full responsibility, create their own exchanges, or some states that were not quite sure about whether they could handle the infrastructure could actually have a partnership with the federal government, where the federal government would help them with the exchange. Or some states would say, I don't want to deal with it entirely, and the federal government would then set up the exchange on their behalf. And they had requirements of what kind of insurance could be on the exchange. There are 4 types of insurance: the bronze, silver, gold, and platinum. So if you're young and healthy, you'd go with the bronze because your premium would be less. You would pay less every month. But if you did get sick, if you got a car accident or somehow ended up in the hospital, then your copay would be much larger than in the other plans. On the other hand, if you're elderly or have multiple chronic diseases, you would actually opt for the platinum plan because you would pay more in premiums, but your copay would be less. And it would look something like this. So your out-of-pocket limit before the insurance company started to pay 100% of your cost, if you had the platinum plan, you would have $2,000 out of pocket per year. You'd pay higher premiums, but the maximum amount would be $2,000 out of pocket. Am I still connected? Something just popped off my screen.
We see you. We hear you.
Okay, fantastic. And so, oh, I see. Something weird happened here. Let's go back. Okay, so if you had the platinum plan, you would then pay higher premiums, but you knew your out-of-pocket expense would be less. If you had the bronze plan, you were banking on not getting sick. You paid less premiums, but if you did get sick, your out-of-pocket would be so much more. So that is the exchange. And then finally, they expanded Medicaid. So Medicaid is the insurance for the poor. And unlike Medicare, Medicare is actually administered entirely by the federal government. Whereas Medicaid, there are 50 different Medicaid programs out there because each one of the states has its own Medicaid program that is mostly funded by the federal government and partially funded by the states themselves. And they can set all the requirements, eligibility, how much they're going to pay, what services they do. So each state can actually have control over their own Medicaid. And this was to expand Medicaid to cover more people than Medicaid covered prior to the ACA. And so the idea was that it would actually cover 24 million more people under Medicaid. And it would be tied in with these exchanges so that people who were eligible for Medicaid, instead of having to go to some office in Sacramento, fill out tons of paperwork and send it back and forth, they'd just log on and they'd be able to be eligible for Medicaid through these exchanges as well. And it was a sliding scale subsidy, so that if you made more money, you paid more in terms of your premium. If you made less money, then they would actually cover more of it. And for whatever reason, I never understood this, but they benchmarked it against the second lowest cost of the silver plan, right? There's a bronze, silver, gold, platinum. They benchmarked it against the second lowest cost health plan in the silver category. So how did that work? So let's say if you are eligible for Medicaid and the second cheapest silver plan, it has a premium of $265 per month. Then if you made 100% of the federal private level, which was about $970 per month, then you pay nothing and the federal government would pay the entire $265 monthly premium. If you earn 200% of the federal poverty level, which is about $2,000, then you would pay 6% of your income, which is about $123 of this $265, and the federal government would pick up the rest. If you made 400% of the federal poverty level, which was about $4,000 a month, then you would pay 9.56% of your income for it, and that turned out to be $265, which meant the federal government would pay zero. And if you made more than that, obviously, you paid the entire premium, which would have been you and me if we had gone on to the exchange. Now, what's really interesting and kind of smart, I thought, is that the second and third columns don't change. So if insurance costs skyrocket, these people are still protected because they pay a percentage of their income rather than a percentage of whatever the premiums are. So if instead the monthly premium was $500 or $800 or $1,000 a month, they would still end up paying the same amount, either like at 200% of the federal poverty level, they'd pay 6.34% of their income rather than some percentage of the premiums. So that made ensured that it would always be affordable for the people that are on the margins of society in terms of socioeconomic status. And so Medicaid, as we said, there are 50 different Medicaids. There's actually more with, there are American Samoa and Guam and the American Virgin Islands, that sort of thing. But for all intents and purposes, there are 50 Medicaid programs out there. And prior to the Affordable Care Act, what they covered is they covered elderly people, they covered children, and they covered parents to a certain degree. But if couples were together, in many states, they wouldn't cover that. And so in some ways, Medicaid actually drove families apart because women would be able to qualify for Medicaid if there was not a man in the house. So that was a problem. The expansion included people that were single that fell below 138% of the federal poverty level, which had not been covered before, and they also covered families that included both a mother and a father. So that was good progress, and that would account, as I had mentioned earlier, about 24 million people. So this gentleman, for example, who's homeless, or these gentlemen, you can see a couple others in the background, before the Affordable Care Act, he would not qualify for Medicaid. After the Affordable Care Act, he would. And how did the Medicaid expansion work? Well, the federal government says, we're going to give each state a big chunk of money, and we're going to ask the states to contribute a little bit of money into this Medicaid so we can enroll all these new people into Medicaid and pay for them. And the reasoning was that this was actually a very good thing for both the federal government and for the states, because the federal government would give for every new Medicaid enrollee, the federal government gives this chunk of money. And what that would do is reduce the number of uninsured in that state. So somebody who previously didn't have insurance now had insurance, walks into the emergency room, gets care, and they have insurance. So that means the hospital gets paid, that means the doctors get paid, and so there is more revenue going into that state. And then the state itself is saving money because normally if every state has to set aside a certain portion of money for those uncompensated care. So if a hospital admits somebody to the hospital who has no insurance, somebody's got to pay for that. And so states usually support that. Now, if all these people are insured, the state can actually save and use that money for something else. And because this money is flowing into the state, you're also going to see increased economic activity. So it sounded like a pretty good idea. In fact, the federal government said not only that, is for every new Medicaid enrollee in your state, for the first 3 years, we're going to pay 100% of the cost. And then starting in the fourth year, we're going to have you pay 5%. And then by the sixth year, we're going to have you pay 10%. But forevermore, we're going to pay 90% of all the costs of any new Medicaid enrollee. And so, that sounds like a pretty good deal. Well, the states did not like it. The states had their own problems. What they had seen, and we had mentioned this yesterday, what they had seen is they had seen their budgets being eaten up by Medicaid expenses. So over time, they were spending more on K through 12 education, but as Medicaid spending increased in their state, there was a flip, and they were now spending more on Medicaid. So in 2014, 25%, this is a conglomeration of all 50 states, 25% of the state budget was going towards paying for Medicaid. 4 years later, they're absolutely right. 29% of their budget in 2018 was going to Medicaid. And so what they're seeing, the projection was just like the federal government, that the fastest growing portion of each state's budget was their Medicaid costs. So the federal government is worried about Medicare, Medicaid, Social Security, Medicare being the fastest growing portion of the federal government, while the fastest growing portion of the state budget is Medicaid. And so the states said, no, we don't care that you're going to pay 100% for the first 3 years. We are not going to be able to afford that 10% in 6 years. And by enrolling all these people, you are going to bankrupt the state. And so many states actually fought this. And they went all the way up to the Supreme Court. And this is the old Supreme Court. Scalia's gone, and Breyer's gone, and Kennedy's gone. So this was the old Supreme Court. And they actually ruled that the Medicaid expansion would be a voluntary option. Because in the Affordable Care Act, what they said was they told the states, we want you to do the Medicaid expansion. And if you don't do the Medicaid expansion, we're going to withdraw all Medicaid funds from that state. And the Supreme Court ruled that that was overly coercive, and therefore said that it must be a voluntary option, that they could do the Medicaid expansion if they want to. And also, there was the Republicans and others that were fighting the individual mandate, and they ruled that it was constitutional because it was a tax, and the federal government is allowed to tax. So they said that even though nowhere in the in those 11,000 pages did they ever say that the individual mandate penalty was a tax, somehow the Supreme Court came up with that and said, yes, it's a tax, so therefore it is constitutional. So then what we had is we now introduced the first level of complexity, is that some states decided to do the Medicaid expansion and other states decided not to. So the states in blue decided to do the Medicaid expansion. The ones in light blue are considering it or have been moving in that direction as of about 7 months ago. And the ones in orange have not done the Medicaid expansion. And what's so unfortunate about this is if you can see all those states, North Carolina, South Carolina, Georgia, Alabama, Mississippi, Texas, those are the poorest states in the union and therefore have the highest number of people that fall below the poverty level and cannot, and therefore they would not be eligible for the Medicaid expansion because they are not, their states have chosen not to comply with the Medicaid expansion. So that's Medicaid. All right, so that's how the Affordable Care Act planned to insure every American. And I say American because they were never, because of all the debates in Congress, they had never planned to insure anybody else who is not a U.S. citizen. Okay, and the second part of this three-legged stool is to reform health insurance. Now, health insurance was really out of control. They were deciding who they would insure, who they wouldn't. So people who had pre-existing conditions, if they had hypertension or if they had cancer in the past, and they were covered by the employer's insurance, and then they switched employers, or they decide to go out and get insurance on their own, the insurance companies say, no, you have a pre-existing condition, we don't want to insure you. So basically, the insurance companies were insuring only healthy people. In fact, I ran afoul of that. I was doing my fellowship up at UCSF in cardiac anesthesiology, and I was covered by the university's health insurance. I had chosen Kaiser, and so we were very happy with it. And it was really it gets very kind of foggy up in San Francisco. My nose was running up all the time. So I went to see my primary care doctor, part of my regular checkup, and I mentioned that my nose was running all the time. And so she referred me, for whatever reason, referred me to an ENT. So I went to see an ENT, very young, just out of residency, who took a look up my nose. No, I don't see anything, but I think we should get an MRI. I said, you know, I've got a runny nose. I don't think I need to get an MRI. So I never went and got that MRI. And then I finished my fellowship at UCSF. I moved down into the Monterey Bay area, and I joined a private practice there. And so I thought, well, okay, you know, we were happy with Kaiser. I'll just re-enroll in Kaiser. So I called them up, and they said, fine, got all the information. And then a couple weeks later, I got this letter in the mail saying that we will not insure you because you have a pre-existing condition. And so I called them up and I said, I don't have a pre-existing condition. And they said, the fact that you did not get that MRI puts you in the category of pre-existing condition, therefore we can't insure you. I said, okay, well, to heck with you. I'm going to go find somebody else to insure me. And they said, oh, you can't. I said, why not? Because in order to get insurance from another insurance company, you have to have a certificate of insurability, and we won't issue that because we're not going to give you health insurance. And so I was in a position that I couldn't get health insurance from anybody. Fortunately, because I kind of know other stuff, what I did is I formed a professional corporation. It has to have more than one employee, hired my wife as an employee of the corporation, and then we could get small business health insurance. But there were millions and millions of people out there that were in the same situation as me with pre-existing conditions that could not get health insurance. And so that was a problem. And also, there was also other people that had insurance that would have some terrible calamity that happened to them, spend a month in the ICU, run up a huge bill of millions of dollars. And at some point, the insurance company would write them a letter and say, oh, okay, we're done. We have a lifetime cap of $1 million on your health insurance policy. Therefore, we're done. We paid our $1 million. You now no longer have health insurance. And so they would do all of these things, and they were making 50% profits because they were only insuring healthy people. So the Affordable Care Act made certain requirements on the health insurance company. First of all, they said the insurance companies could not have pre-existing condition limitations. They also eliminated lifetime limits. No health insurance policy can be written with lifetime limits or pre-existing conditions, and that there had to be guarantee issue and guarantee renewal. So they can't say at the end of a year, oh, well, you cost us too much, we're not going to renew your health insurance. They have to renew the health insurance, and they have to issue it if you qualify, which meant that, if you're looking for a particular insurance and it says for people 18 to 24, and you're between 18 and 24, you qualify. And also communal pricing. So they couldn't say, oh, because you have a certain kind of lifestyle or because you smoke or drink or something else or do drugs, that we're not going to insure you or we're going to charge you more. No, they have to insure you based upon the entire community, whether it be by zip code or by some other demographic. They have to insure based upon some communal pricing. Also, in every insurance policy, there was this essential health benefits. That every insurance policy written must have certain essential health benefits that's reviewed every year by the Secretary of Health and Human Services, but in the last 10 or 12 years hasn't changed one iota. So that you would have laboratory services, prescription drugs, emergency services, maternal care, pediatric care. Now, there are people that complained about these 10 essential health services because they say, I'm a single male, why should I be paying for maternity and newborn care? But that debate aside, every insurance policy had to have these 10 essential health benefits, and then every year the Secretary of Health and Human Services theoretically would review it, and if they changed the list, then every policy moving forward had to have the new list in there. So this was a big step forward, and actually Obama got himself into some trouble because he said, if you have health insurance, you can keep it. Well, what happened was that many of these people that did have health insurance that didn't include these 10 essential health benefits, that actually had substandard health insurance, the insurance company canceled them in order to be compliant, and therefore these people had to get new health insurance, and they complained about that, but actually they ended up with better health insurance overall. And then also the ACA set the medical loss ratio at 80%. Now, I had mentioned that the insurance companies were making 50% profits. Well, this set their profit ratio at 20%. They cannot make more than 20% profit. So they collect premiums, and they have to pay out at least 80% of those premiums for services that their subscribers require, hospitalization, laboratory, all that sort of stuff. If they pay out less than 80%, then they have to refund the difference back to their subscribers. So this was good, and the health insurance companies went along with it because they realized they were going to be insuring so many more people, millions and millions more people, that the profit they were making on a small number of people, 50% profit they were making on a small number of people, now they're insuring a large number of people, they're getting a smaller profit, but they would actually end up with more money overall. So they went along with that. Okay, and then the third thing is improving quality and reducing cost. So after the Affordable Care Act, we were all walking around talking about the triple aim, and that was having a better patient experience, better health outcomes at a lower cost. So a lot of hospitals really got on board with this and really thought about how they could really make the patient experience better, putting the patient at the center of our care rather than putting the doctor at the center and everybody, all the patients have to sort of, do work around the doctor's timing, actually putting the patient at the center and having everybody coordinate care around the patient. And to a certain degree, I think this concept is working and that we are moving in that direction more speedily than I would have thought. Better health outcomes. We're always, we talked yesterday about all the things that we could do better, and certainly this was an aim of ours, and obviously lower cost, right? That's what the federal government was so adamant about. And we really have to be concerned about that because the federal government is worried about Medicare, the states are worried about Medicaid, and the businesses are worried about the raising costs that they're paying towards their employees' premiums, and the families are also concerned about it as well. So it's all across the board. The higher costs are really worrying us all. The goals by the ACA was to reduce healthcare spending from 17% of the GDP down to 6%. We're not there. We're nowhere close. We're probably about 17.9%. The good news is that the pandemic actually resulted in less healthcare utilization, and so people who had elective surgeries or elective procedures did not go into the hospital, did not have those procedures. So we actually saw for the first time a drop in healthcare spending as a percentage of our GDP, about 0.5%, but we're nowhere close to ever getting down to 6%. So, and also to reduce the federal budget by $143 billion over 10 years. It's only gone up. We haven't seen any reduction at all. And then there were a whole ton of programs that were put into the Affordable Care Act, and you may recognize some of these, and they funded a lot of these with the whole idea of this triple aim. Accountable care organizations were to take all these little things. So somebody owned a radiology center out there, and somebody owned a laboratory out there, and somebody else owned a little ER, to actually get all these people together, all these different little companies together, to create a large conglomeration where they would share resources and make things more efficient and hopefully save money. And so a lot of people jumped on board with this. A lot of organizations jumped on board with this, but it really hasn't panned out. Patient-centered medical home, actually redoing our structure so the patient is at the center of our care, giving primary care physicians raises so that more medical students will go into primary care. And then also Medicare and Medicaid services. There was this whole idea of bundling services. Instead of paying the surgeon for a gallbladder and the anesthesiologist and the hospital all separately, that they'd say, somebody comes in for a gallbladder, we're going to pay $3,000. You guys decide how you're going to split it. And they thought that that would actually save money as well. The Independent Payment Advisory Board, this was a board that they would constitute. So if Medicare payments got out of hand, that they would actually, this board would convene and figure out how to save money. And it's never convened because the Republicans jumped all over it. They call it death panels and everything else, that somehow they would deny care to elderly people and allow them to die. So this, the Independent Payment Advisory Board has never been convened. Pay for performance was this idea that if you improve your care and you deliver better care more efficiently, you'll get rewarded for it. You're going to save money, but you'll get a reward in some way. Some portion of that savings will go back to you. Independence at home, to try to get people out of nursing homes and back home where they want to be, and figure out how to do that efficiently. This Patient-Centered Outcome Research Institute, which is what the HPRI here on campus does a lot of, and medical malpractice reform didn't go anywhere. And then financial disclosure, this is the reason why if you go into hospital, the most a pharmaceutical company can give you is like a pen. Before they'd fly you to Hawaii and do all these things. Well, now they don't do that. And then also National Strategy for Prevention and Wellness, again, a program that really never took off. And the last one, nutritional information labeling requirements. This is actually one thing that did happen. So now all foods are required to have nutritional information on. Before it's kind of voluntary, only some foods did it. Now labeling requirements are on all foods. So people can see what they're eating and hopefully they will eat more healthy. Now cost is a big deal, right? So the Affordable Care Act had to have a way that it wouldn't increase the budget, would not increase the deficit, would not increase borrowing. And so the whole idea was the Affordable Care Act was going to pay for itself. And this is the way that they conceptualized it, that they would actually, over time, they would actually get more and more income based upon increased taxing. First of all, they would increase the Medicare tax for people that were higher earners. So I saw a second line on my pay stub deducting Medicare and then Medicare for higher earners. So that did happen. They figured that they would penalize people for not complying with the insurance requirements and that they would get money from the individual employer mandate penalties. They also were taxing the health insurance companies because they were making more money. They would tax them more. They would also tax Cadillac healthcare plans, those that did not fall within the bronze, silver, gold, platinum plans that somebody who was a CEO of a company said, I want my own healthcare plan that's much better than anything else out there. Well, then there was a special tax on those. There was a fee on pharmaceutical companies, and you can see the fee is very small because of this deal that they cut before the bill was passed, and then a fee on medical device manufacturers and a bunch of other taxes as well. So they said, okay, Obamacare is going to pay for itself. This will be great. So we're not going to increase the deficit. And it looked like it worked. You saw this slide yesterday. So once it got enacted, we saw the number of uninsured people drop from 54 million down to 42 million. Now, in terms of expenses, now this slide looks deceptively simple, but this is really the crux of the problem. So you remember the President Obama got up there before the joint session of Congress and said, cost is our big problem. Therefore, we are going to have the Affordable Care Act. And the Affordable Care Act had all this stuff in. And here is what the Congressional Budget Office, which is a nonpartisan portion of the federal government that kind of figures out how much things are going to cost and everything. Well, the blue line is how healthcare spending will increase over time, and it goes from 2010 to 2035, how healthcare expenses will increase over time without the Affordable Care Act. And then that's a red line. And the blue line is how healthcare costs will increase with Obamacare. So 11,000 pages, and it doesn't do a single thing to reduce the cost of the rising cost of healthcare in the United States, which is our big problem. And that is the true failure of Obamacare. Fortunately, that was 2010. In 2014, they redid the projections, and they said, oh yeah, it might bend the curve a little bit. Rather than by 2039, having it 9.6% of the GDP, it'll be about 8% of the GDP. Right now, we're at 7.9% of the GDP, so I'm not sure. I mean, we still got 20 more years to go. Unless we do something pretty drastic, I'm not too sure that we're going to make it 8% of the GDP. But you can see that Obamacare has done a lot of wonderful things, but didn't solve the fundamental problem about rising costs of healthcare. So before the Affordable Care Act, we had 50 million people that were uninsured. Patients with pre-existing conditions could not get health insurance. Healthcare costs were rising faster than any other part of the federal budget. And healthcare costs were the #1 reason that people were seeking bankruptcy. And after the ACA, it made healthcare affordable to all Americans, regardless of their income. Great, good step. Caused a drop of the uninsured from about 50 million to, actually it's about 30 million right now. And eliminated pre-existing conditions, removed lifetime limits, and required those minimum benefits for every policy. So that was really great, but the problem is not only costs, but we still have about 30 million people that are still uninsured. And that, I think, is a big problem. And who are these people? Well, they fall into 3 categories. There's what we call the coverage gap. This is my last topic. The coverage gap, the family glitch, and undocumented immigrants. So what's the coverage gap? Well, in those states that decided not to expand Medicaid coverage, there are people who fall into the coverage gap, because traditional Medicare before the Affordable Care Act covered people up to 50% of the federal poverty level, and then the exchanges kick in, that sliding scale subsidy kicks in at 100% of the federal poverty level. So for states that did not expand their Medicaid coverage, there are people that are between 50% of the federal poverty level and 100% of the federal poverty level that continue to have no coverage. And we estimate that's between 3.7 million and 8 million people that cannot get coverage because they fall into this gap. There is also what's called the family glitch, which I think by now has been solved. But if you remember, there's that employer mandate that if an individual cannot afford whatever the health insurance that's being offered by the employer and goes on to the exchange, they will get the subsidy. But for some reason, when they were putting this all together, they never took into account the family. So you don't get that same degree of coverage if you decide not to get use your employer coverage and you go on to the exchange. You cannot get the family coverage. I think they've solved this problem, but there were about 2.5 to 10 million people that were caught in this particular family glitch. And then there are the undocumented immigrants, and we're not too sure how many there are because they're undocumented. Somewhere between 11 million and 33 million people in the United States are undocumented. And because they are undocumented, they are not part of the normal mainstream of being able to go and qualify for either the exchanges or for Medicaid. And so they account for a fairly large portion of people that continue not to have health insurance. And, it's really unfortunate because there are other countries that if you are even standing on their soil, you're covered for health insurance or you're covered for health care. So if you're visiting, you're a tourist, you're on that, and you get sick, you go to the hospital, you're covered. There are other countries that maybe are not as kind to tourists, but people that are there and somehow are working and earning an income and contributing to the society tend to be covered. So almost all of the first world countries that are comparable to the United States all have universal health care coverage. And when people are asked in those countries how much they think Americans pay, for example, a C-section or to get the gallbladder taken out, they come up with, $250 or something. When you tell them it's, $20,000, they're just astounded. So there are a lot of infrastructure problems that we still have to solve. The real question is, how are we going to do it? And you and I, sitting here as individuals, we don't really have, other than trying to do our best to deliver the best care possible to each and every one of our patients, we don't have the resources, the clout, the ability to really change all this stuff. This stuff happens in Congress, this happens in state legislatures, this happens in regulatory agencies. And that is one reason that people do go and get degrees in public health and go and try to craft changes or come up with ideas of how things ought to be changed, get those ideas out there so that when they are crafting a legislation, they can look at those ideas and see if they will fit in to the larger picture of how we're going to move in the direction of achieving that triple aim, delivering better care at lower costs. All right, any questions?
Okay, so we heard some really necessary information about what the ACA actually is, what it does. I'm hoping this makes sense in the context of what was discussed in the session immediately prior. But does anyone have questions about the ACA in general or around what it allows for, what it does, what problems it solves? As always, feedback is open for this session at the same Poll Everywhere link, pollev.com. AHPE 2021. But the floor is open, chat box is open for any questions about the ACA.
I have a question, Dr. Kelly. So there's been attempts to, I guess, cancel out the ACA, various attempts that have failed. But what, I guess, if those parties were successful, what would have happened to the ACA as we know it?
It would have immediately put approximately 50 million people out of health insurance. Yes, and so I think there were over 70 attempts by the Republicans to try to overturn the ACA in a number of different ways. And long story short, I mean, we could spend 2 more hours talking about this, and I'm not going to. But the short of it is they tried and tried. And then finally, it seemed like they gave up. But then Trump came in and said that he was going to repeal the ACA, put new life into it, and they finally figured out a way to do it. They say because the Supreme Court said that individual mandate is a tax, what they did in 2017, 18, something around there, is that they said, okay, we are no longer, as part of one of the bills, we're no longer going to penalize people for not having health insurance, and therefore it's no longer a tax. And so so now then they decided that they were going to sue to say if it's not a tax, that makes the individual mandate unconstitutional. And if the individual mandate is unconstitutional, then the entire Affordable Care Act is unconstitutional. And they shopped it around and found a federal court in Texas that they thought would be sympathetic to this particular argument. And indeed they were. And so they won at the trial court level. Then they took it up to the appeals court level, and they won at the appeals court level. And then they took it up to the Supreme Court of Texas, and the Supreme Court of Texas turned it around for some technical reason, sent it back down, and it went back up. And then now it's before the Supreme Court of the United States. And if the Supreme Court of the United States decides, yes, indeed, now that the individual mandate is no longer taxed, that makes individual mandate unconstitutional. And if the individual mandate is unconstitutional, then the entire Affordable Care Act will be unconstitutional. Then yes, indeed, then 50 million people will be out of health insurance. But I guess people are confident enough, because if they were worried about it, then there'd be somebody in Congress that would be coming up with some plans, because now that they control Congress and almost control the Senate, and they also have a Democrat in the White House, they would be shoring up plans to make sure that doesn't happen.
That'd be unfortunate if that day ever came.
Absolutely, absolutely.
And also, Dean, today our evening session is all about different reform efforts that have been attempted to affect the Affordable Care Act and where we kind of are politically now around this discussion. So definitely stay with us for our evening session starting at 6, back with Dr. Flagg.
Awesome. Thanks, Kelly.
Yeah, you're welcome.
So I mentioned this yesterday, but I don't know if you would have any input on it, Dr. Kelly, regarding pharmaceutical companies and their impact on the rising costs of healthcare. One of the things I mentioned was how they have like a pervasive nature of reeling in patients with their prescription savings plan. If they can't afford it, if their health insurance doesn't cover like a newer medication, pharmaceutical companies will be like, well, you could sign up for this program and we'll either reduce the copay down to $5 or you'll get for free. But then after a year, it's back to square one, if you know what I'm referring to.
Yes, I do. Yes, I do. Yeah, and it's pretty complicated because it depends on what sort of demographic you're part of, right? If you're over 65, you qualify for the prescription drug benefit, which is, I think, Medicare Part D. And that in and of itself is complicated. There's a donut hole where, it pays for a little bit. And then there's this hole where that's called a donut hole because that's where the person, the patient, has to pay, and then catastrophic health care kicks in. And so and then you have the people between ages of 18 and 65 who have health insurance. And if you have health insurance, it depends on what kind of plan you have, and they play all sorts of games with that. And if you meet your deductible, then all your insurance, all your prescriptions are free, but you may actually have to pay for all your entire deductible of $6,000 or whatever it is in order to get to that point to pay for your pharmaceuticals. And you have the people that are uninsured or Medicaid, Medicare. But the thing is that it's actually kind of complicated, because these drug companies will then negotiate with, there's actually an intermediary, but they will negotiate with the insurance companies to discount it. So they'll price it thousands of dollars, and then they'll say, well, for yours, if you push our drug, we will, give you, a couple $100. And then they can also negotiate with hospitals. I mean, they do all sorts of things. And then for people that they think can't afford it, they have all these things where you fill out a form and then they give it to you for $3 a pill or whatever. I mean, it's ridiculous what they do. But in terms of overall healthcare costs, consistently, the pharmaceuticals have accounted for about 10% of all healthcare costs. I think that we subjectively feel like we're paying a lot more for pharmaceuticals than we ever did, and we probably are. But in terms of the overall expenditures, it's been pretty steady at 10%, which kind of surprises me, because my sense is that it's going up. I mean, my son has Crohn's disease, and we just started him on a new medication, and it was an infusion that gets once every 4 weeks. It goes 4 weeks and 8 weeks, and we go up. The infusion, the 30-minute infusion, is $37,000. Of course, I got health insurance, so I'm okay. So that took up my entire deductible. And it goes for the second infusion, and because I've met my deductible, the cost is zero, right? So go figure, right? It's still $37,000, but the insurance company says they're paying. But then if you look at it very closely, it's the $37,000 been knocked down to like $600. So there's a lot of funny money out there, the way that they play these games. So it's not always the cost that you see, it's the negotiated cost. So again, it's a very complicated area that even I don't fully understand. So, but yes, they are making money. They're making good money, but it doesn't seem to be one of the areas that's expanding in terms of the percentage of overall healthcare costs.
Awesome. Thank you so much for your time and the feedback. I'd love to chat with you sometime. I don't know if you're in 53 today, but I'm right down the hallway.
Yeah, absolutely.
Well, thank you so much for being with us, Dr. Kelly. This is a necessary talk. Most trainees, especially, and those even in professional spaces in healthcare, don't understand what people are talking about when they mention the ACA. So this is a really core lecture for this elective. And I hope as we move through the rest of this elective, talking about how insurance is really an access point, especially for different populations. I hope you understand how a lot of those problems were fixed through this piece of legislation and how it has a lot left to be desired. So thank you for outlining that so clearly with us today. And if you have other questions for us, by all means, email us. Reese and I are happy to field some of those questions, if not dole them off to Dr. Kelly. But our next session starts at 6 p.m. today. So go ahead and grab dinner, bio break, etc. And we'll talk a little bit more about those reform efforts. Again, feedback survey is open.